to GenCen's October colloquium. My name is Dr. Stephanie Nowen. I use she, her pronouns, and I am the director of the Center for Gender and Global Context, or GenCen for short. And it is my absolute delight to have Professor Carla Pfeffer, who's relatively new to MSU, joined our faculty last year. It's my delight to have her speaking today. Just a few quick notes. You will be receiving a Qualtrics survey to fill out that we would really appreciate if you completed that. It's very short, and it helps us understand who's coming to our colloquium, our colloquia series, and what they're getting out of it. And we use that both to guide future activities and, of course, to report to our dean to let them know that we are indeed an important center that needs to continue to receive funding. Again, I'll jump right into it. It is my pleasure to introduce Dr. Carla Pfeffer, who's going to be talking about her research today, Reproducing Normative Bodies and Social Citizens, Medical Decision-Making Around Withholding Testosterone in Transgender Pregnancy. Dr. Pfeffer is the director of the Consortium for Sexual and Gender Minority Health, an associate professor in the School of Social Work, affiliated faculty in the Department of Sociology, and core faculty in the Center for Gender and Global Context here at MSU. She completed her PhD and MA in sociology, a graduate certificate in women's studies, and an MSW in social policy and evaluation at the University of Michigan, where she received interdisciplinary, multi-method training in the social sciences and humanities. Her research is at the intersection of critical inquiry into contemporary families, genders, health, sexualities, and bodies considered marginal, as well as social actors' management of stigma and discrimination processes. Her research has been funded by the Economic and Social Research Council, the Andrew W. Mellon Foundation, and American Council of Learned Societies. Her book, Queering Families, The Postmodern Partnership of Cisgender Women and Transgender Men, was published by Oxford University Press in 2017. Her scholarship has received awards from the National Council on Family Relations and the American Sociological Association sections on sex and gender and sexualities. She has taught undergraduate and graduate courses focusing on race, class, gender, and sexualities, sex, gender, and society, body and embodiment, the family, LGBTQIA+ identities, social problems, feminist theory, methods and epistemologies, qualitative methods, and social work practice with women. In her previous faculty position at the University of South Carolina, she was Associate Professor of Sociology and Women's and Gender Studies and served as the Director of the Women and Gender Studies program. In the American Sociological Association, she has served as elected chair of the section on sexualities and secretary-treasurer of the section on body and embodiment. She served as an invited reviewer for NSF, Austrian Science Fund, Health Research Council of New Zealand, National Science Center of Poland, American Council of Learned Societies, the Andrew Mellon Foundation, 80 journals and academic presses, and is on the editorial boards of Fat Studies, Gender and Society, Journal of Homosexuality, Journal of Marriage and Family, Michigan Feminist Studies, Sociological Forum, and Socius. Dr. Pfeffer is currently conducting analyses from a 3-year international study focusing on transgender pregnancy. So, Dr. Pfeffer, I hand you the mic. Thank you so much for coming today.
Oh, thank you so much. I am going to get some slides going, so give me just a second to get that happening. Are you able to see everything just fine?
Yes, looks great. Thank you.
Okay. Let's see here. Oh, unfortunately, I'm not. I'm going to restart that. Hold on just a second. Here we go. Still good?
Yes, looks great.
Wonderful. Okay. All right. All right, here we go. So hello, everyone. Thank you for coming today. I want to thank Stephanie and Edwin and the Center for Gender in Global Context for the opportunity to present new analyses from international work that my collaborators and I, Sally Hines, Ruth Pierce, Damian Riggs, Elisabetta Ruspini, and Frances Ray White have undertaken in the context of our transgender pregnancy project that's been funded by the Economic and Social Research Council in the UK. The analysis I'll be presenting to you today focuses on reproducing normative bodies and social citizens, medical decision-making around withholding testosterone in transgender and non-binary pregnancy. Medical expertise and authority often serve as foundations upon which patients' uptake of medical advice is built, and possibilities for health-focused behavioral changes in patients' lives are both motivated and compelled. This expertise and authority, however, they don't emerge in a social vacuum, and they're often constructed and operationalized through processes of medical social control, surveillance, and bureaucratic technologies, particularly in the context of ambiguity and uncertainty. In the case of pregnancy, healthcare providers dispense advice and protocols around nutrition, exercise, pharmaceutical and substance use, mental health, and the need for regular medical monitoring to protect the health and well-being of essentially two patients, the pregnant person and the fetus. But what happens when medical science doesn't yet have all the answers about how particular patient behaviors may impact health outcomes for both the pregnant person and the fetus, particularly when the impacts of some behaviors may create potentially divergent health outcomes for the pregnant person and fetus? How do patients and providers understand and weigh relative health risks and benefits as they formulate, dispense, or work to interpret and follow medical advice at this complicated intersection? How might assessment of health risks and medical advice for behavioral change reflect historical and ongoing social practices for creating ideal and normative social citizens? In this work, my colleagues and I draw upon in-depth interview and focus group data from a 3-year international study of 70 trans men and non-binary people residing across Australia, Canada, the European Union, and the United States about their intentions and experiences around pregnancy, as well as 22 healthcare providers practicing across Australia, Canada, the European Union, and the United States with self-identified experience working with trans and non-binary patients and pregnancy across a diverse cross-section of specialty areas that include psychotherapists, general practitioners, endocrinologists, midwives, lactation consultants, OBGYNs, and fertility specialists. The central motivating questions guiding this work are: for trans and non-binary people who are taking testosterone, what's the medical advice and guidance around stopping or pausing testosterone to become pregnant, throughout pregnancy, and during the postpartum period, particularly in the context of chest feeding? What's the evidence base in the medical empirical literature for this guidance? And how do trans and non-binary people respond to this guidance? The answers to these questions may be quite impactful for trans men and some non-binary people, as testosterone supplementation among these populations generally serves to reduce gender dysphoria, protect mental health, and provide a greater likelihood of being recognized by social peers in accordance with one's gender identity. These answers may also be potentially impactful for the offspring of those receiving and following various advice. Our understandings of biological and social reproduction and what constitutes men's versus women's hormones, ongoing legacies of eugenics, and how individuals and their healthcare providers make determinations around their own and others' social fitness, health, and well-being. Like cisgender men and women, some but not all transgender men and non-binary people pursue hormone therapy to raise their testosterone levels. Testosterone replacement or supplemental therapy may be administered orally, topically, transdermally, and through injection subcutaneously or intramuscularly. The effects of testosterone administration include, but aren't limited to, facial and body hair growth, lowering of vocal pitch, facial squaring, clitoral growth, absent or infrequent menstrual periods, acne, balding, muscle development, increased libido, and redistribution of body fat. For many trans and non-binary people, testosterone therapy is also associated with considerable improvement of mental health, including reductions in depression, anxiety, and social distress. While testosterone is widely considered a male hormone, all people have testosterone, and the variation in testosterone levels among cisgender men is greater than the mean difference between cisgender men and cisgender women as groups. So, for example, among cis men, serum testosterone levels in the range from 320 to 1,000 nanograms per deciliter are generally considered normal, and values from 15 to 70 nanograms per deciliter are considered normal among cis women. Among those individuals with the most common cause of infertility related to ovulation, polycystic ovary syndrome, or PCOS, testosterone levels can range from 1 to just over 200 nanograms per deciliter, so somewhere between the levels of those for men and women. There is no universal or standard dosing protocol for trans men or non-binary people undergoing hormone therapy with testosterone. However, the Endocrine Society has issued treatment guidelines suggesting supplementation with testosterone until serum testosterone ranges fall within the normal ranges for cis men. Such clinical guidelines, which have become fairly normalized in practice, further instantiate and reproduce sex and gender binaries that may not fit with the actual desires of many trans and non-binary people. However, some trans and non-binary people have resisted the prescriptive sex-binarized dosing of testosterone and other hormone therapies by crowdsourcing information online, microdosing, banking or sharing testosterone, and tailoring customized dosing on their own if they're unable to find or access healthcare practitioners willing to work with them to achieve their aims. In some countries and jurisdictions, both historically and today, trans men and non-binary people are required to undergo hysterectomy and bilateral salpingo-oophorectomy, or removal of the uterus, fallopian tubes, and ovaries, in order to be considered eligible candidates for medically facilitated testosterone therapy, or to be classified legally as male. These medicine and state-sponsored enforcements of sex and gender binaries echo eugenic practices as they work to preclude possibilities such as the existence of pregnant men and transgender reproduction. As Renee Melling notes, from the earliest days of medical specialization, physicians positioned the male body as a neutral medical standard and the female body as reproductive. Even within the past decade, some medical literature regarded trans pregnancy after the initiation of testosterone therapy as physiologically impossible. Despite this, pregnant men and non-binary people have become increasingly socially visible as they form contemporary queer families, even as the media treats the figure of the pregnant man as perennially new over decades of coverage, a sort of gendered Groundhog Day. It's in this context of binary social and medical understandings of sex and gender that trans men and non-binary people navigate both hormone therapy and reproduction. Current medical guidance around trans and non-binary pregnancy reflects these same binary logics. As Melling notes, cultural beliefs about male and female as separate and opposite sex categories have undergirded the production of so many forms of biomedical knowledge, including in the realm of reproductive health. For example, trans and non-binary people seeking to harvest and store their ova to become pregnant, or who discover they're pregnant, are medically counseled to discontinue any hormone therapy they may be taking immediately, throughout their pregnancy, and in general until they're no longer chest feeding if they choose and are able to chest feed. This medical guidance for trans and non-binary people is based largely on understandings that testosterone, as a quote-unquote male hormone, is incompatible with conception, pregnancy, and lactation as quote-unquote female biological processes, as well as concerns about potential impacts of preconception ova, prenatal embryonic and fetal, and postpartum infant exposures to what has come to be termed excess androgens. Medical studies of the potential impacts of excess androgen exposure on ova, embryos, fetuses, and infants do exist. However, vis-a-vis the aforementioned individuals with PCOS, who have become pregnant, given birth, and nursed their offspring. While these empirical studies are largely focused on cisgender women, they provide important lessons for how maintenance of socially normative systems inform medical treatment considerations and practice guidelines, as well as serve as a comparative case for considering the testosterone therapy management experiences of pregnant, trans, and non-binary people. The medical empirical research literatures on impacts of preconception, prenatal, and postpartum exposure to androgens on conception, pregnancy, and development of offspring are relatively scant, largely focusing on natal parents with PCOS, congenital adrenal hyperplasia, CAH, or more recently, trans men and non-binary people undergoing testosterone therapy. PCOS is the leading cause of infertility related to anovulation, but conception is not impossible among all those with this condition. Those with PCOS often report facial and body hair, balding, absent or infrequent menstrual periods, acne, weight gain, depression, and anxiety. Further, a number of empirical studies report associations between PCOS and lesbian and trans identities. Empirical literature expresses concern that the androgenic fetal environment among those with PCOS may program PCOS in the offspring. It also counsels those with PCOS to lose weight, while simultaneously recommending against bariatric surgery, the only weight loss method with empirically supported long-term efficacy, and noting that there is no evidence that losing weight will reduce potential short or long-term health impacts among the offspring of those born to a natal parent with PCOS. Concerns about fetal exposure to excess androgens among offspring born to people with PCOS include, among others, urogenital and intersex conditions, such as an enlarged clitoris or other forms of quote-unquote ambiguous genitalia, and later development of metabolic dysfunction, including obesity and PCOS, and or neuropsychiatric disorders, or what have been termed neuropsychiatric disorders, such as autism spectrum disorder and attention deficit hyperactivity disorder, largely among those categorized female at birth. Social justice activists, scholars, in the field of critical studies have made important strides, highlighting how the desire to maximize the fitness of offspring and guard against development of conditions or human characteristics deemed unhealthy or less than ideal may reflect troubling eugenicist and biomedical moralist underpinnings in ways that further harm already socially marginalized people. Drawing upon Foucauldian theory and analysis, Lauren Freeman argues that contemporary pregnancy in particular has become a site of epistemic injustice through processes of medical professionals and technologies assuming power and epistemic authority over pregnancy and pregnant people, often denying or superseding the epistemic privilege, knowledge, and control that a pregnant person has over their own body and embodied pregnancy experience. To begin filling existing gaps in the empirical literatures, the study I'll share with you today involved a cross-sectional, in-depth individual and focus group interview design, specifically the collection of qualitative interviews with 70 trans men and non-binary people, and 22 healthcare providers who self-identified as focusing their practice with trans and non-binary populations. The work that I'll share with you today stems from a grounded theory analysis of data gathered from these interviews. I'm happy to talk more about our methods during the Q&A, but I want to spend most of our time today sharing our findings. In our findings, some trans and non-binary people described concerns about pausing testosterone in order to become pregnant, throughout pregnancy, and during the postpartum period. Common fears included potential changes in voice, hair growth, or fat distribution that may make public recognition as a man more challenging. Concerns about increased levels of body dysphoria and depression and higher likelihood of postpartum depression, being feminized and misgendered by providers throughout their pregnancy, and worries that providers may not reinitiate testosterone prescriptions following the birth of a child. Most of our participants reported using testosterone as a critical component of their medical care. Many respondents spoke about pausing testosterone administration during pregnancy as a matter of course, as one participant told us about advice they'd received from within the trans community. People did say that taking testosterone while pregnant could cause either miscarriage or grievous birth defects, that it could impact the natural development and balance of hormones in the baby. Another participant stated, there were so many myths. There was a general idea that if somebody had been on testosterone and they had a child, that child would be autistic. That was the perceived wisdom, that was a fact. Participants' decisions about how long they needed to be off testosterone before trying to conceive was also steeped in ambiguity and advice from healthcare professionals that could feel less based in science than in medical professionals' reassertion of authority. As one participant told us, the majority of folks I've spoken with, a lot of people, have had similar experiences where they've been given some arbitrary time frame, like I will or I won't work with you unless you've been off testosterone for X number of months, or this is when I feel like it's safe for you to start trying, or something like that. Participants described confronting many unknowns about testosterone use while pregnant and in the postpartum period, having many questions without answers. One participant wondered, if I take testosterone, will that reduce my milk production? Will it transfer to my kid? I don't know. Again, we don't have any information on that. It's just not known. When asked if he would plan to pause taking testosterone if he planned to become pregnant, another participant stated, yeah, because it's not good for the baby. I don't know of any evidence that hormone replacement therapy can affect the baby, but just according to my knowledge, what I grab on the internet from my other trans peers, I think it's not a good thing for at the time that I'm pregnant. So I'd have to stop that, I think. But in the future, if doctors said, no, you can still take that, it's not a problem with the baby, maybe I would not stop. It's up to the information I have and the opinion and the development of the health service in that time, in that field. Other participants discussed historical cases of hormone therapy during pregnancy and subsequent fetal harm as reason enough for them to pause their testosterone treatment. For example, one participant discussed diethylstilbestrol syndrome, or DES syndrome, which involves a cluster of sequelae, including heightened cancer risk, infertility, and intersex conditions experienced by children born to a natal parent who was prescribed DES, a synthetic form of estrogen, to prevent preterm pregnancy in the 20th century. In the context of so many unknowns, many participants described defaulting to testosterone pause during pregnancy and relying on healthcare providers and future research for key information about whether continuing testosterone therapy is safe for themselves and future offspring during pregnancy. While expectations around pausing testosterone during pregnancy were common among both research participants and healthcare providers, some participants expressed tensions around these expectations or discussed how pausing testosterone impacted them negatively or made them feel like they had less control over their own lives, which certainly wasn't inconsequential to their mental health. As one participant told us, the experience of being off testosterone was so much more of a challenge and so much more dysphoria-inducing than I expected it to be, that it is kind of like left me a little bit adrift almost, like shaken up. I didn't want to go on a journey in terms of my identity, and I just really underestimated how much that whole process would force me to do that and sort of leave me feeling a bit like more of an in-between type person. I feel like I've been forced to be different somehow. Being pregnant wasn't the hard thing. Being off T was the hard thing. I could have just been like a pregnant man in the most straightforward sense of being myself, being on T, and being pregnant. That would have been fine. When asked if pausing testosterone during pregnancy impacted his transition, another participant stated, yeah, toward the end of the pregnancy, I was all, I think I'm going to get back on testosterone gel in a few months' time. I'll feel better. I felt quite good when I was on it. In such instances, trans and non-binary people reported engaging in paused testosterone therapy for the sake of their pregnancies and offspring, even when doing so resulted in them not feeling their best. A considerable number of participants reported struggling with postpartum depression as well, some experiences of which may be compounded by potential or actual delays in returning to testosterone therapy following the birth of their children. As one respondent reported, the only way I can describe it is that before testosterone, my mood and feelings very much felt like a roller coaster. My lows were miserable, depressed to the point of suicidal lows, and the highs didn't really compensate for that. And testosterone just leveled it out. It kind of normalized my feelings. I actually felt like I had some control over how I felt rather than being at the mercy of it. I was also experiencing some depression after having my daughter, and I knew that going back on testosterone would help. I didn't really know whether my doctor would be happy to re-prescribe me testosterone, and there was a fear there that it would be withheld from me. I must admit that it was a big concern of mine that they were going to say, well, sorry, you came off it, you're not getting it back. Respondents often describe the challenges of negotiating with healthcare providers about resuming testosterone as they also faced pressures to chest feed or not chest feed, coped with sleeplessness, managed gendered social expectations around parenthood, and sometimes struggled with postpartum depression or complications of birth. This period was often described as a particularly vulnerable time, during which their bodies and minds were both exhausted, and advocating for their own needs and well-being was even more confusing and challenging. The healthcare providers we interviewed expressed a number of concerns about their patients remaining on testosterone while they were attempting to conceive, during pregnancy, and while chest feeding. Most providers also acknowledged, however, that pregnancy was quite possible while on testosterone, and that they often advise their patients to maintain birth control practices if having sex with people who produce sperm, since ovulation and pregnancy can and do occur during testosterone therapy. When trans and non-binary people taking testosterone sought healthcare after learning they were pregnant, most providers reported that they advised that testosterone therapy be paused immediately due to potential fetal risks. When asked about the sorts of risks they were most concerned about, they often noted that not enough research has been conducted or that it's inconclusive. As one provider noted, "We don't have as much data as I would like. The data that we have suggests that there may be some virilization effects, but we don't have good data." Basically, I would tell him exactly what I tell everybody who asks me about cannabis, which is that we just don't know. There are theoretical risks. There is some data that suggests that the risks may be more than theoretical, but at this point, we don't know. One respondent currently training to become a lactation consultant spoke about not receiving any education around trans and non-binary people, testosterone, and lactation. Another provider noted, "We don't have data on what would happen if you were on testosterone to the fetus. There's just no data on that. Have I had patients that were on testosterone and didn't know they were pregnant and then went on to have a baby? Yes, and obviously everything looked okay. I would never say go ahead and be on testosterone and try to get pregnant and then use testosterone throughout the pregnancy. I cannot say that would be okay because we still consider testosterone a teratogen, even though we don't have that data. They think they should just be able to be pregnant and take testosterone, and I try to explain that we just don't know what would happen to a baby. And it's the same thing with drug use. I mean, is it selfish or is it not? I think if you choose to have a pregnancy, your female hormone levels would be already so high that testosterone probably wouldn't even mentally help. If you're producing breast milk and you couldn't be without testosterone for mental health, if you couldn't deal without testosterone, then you probably shouldn't be pregnant." In these ways, providers often report a paucity of medical training and information in the empirical literature on maintaining testosterone therapy during pregnancy. Yet many advise their patients to pause its use without reservation. Some, like the provider I just quoted, may even compare it to illicit drug use or suggest that testosterone therapy during pregnancy is selfish and ultimately inconsequential for the mental health and well-being of their trans and non-binary patients. This contrasted, however, with self-reports from some of the trans and non-binary people we interviewed. For example, one participant described an attempt to pause testosterone as unbearable. He remarked, "I had come to such good terms with myself and with my body, how I could relate with others, but also generally like how I moved in the world. I really felt whole. And having this prospect of having to give this up was so much worse than what I'd endured before, when I didn't even know how good it could feel to be on T." Another participant describing his emotions, sense of self, and interactions on testosterone said, Suddenly, my feelings were really on time, so I became in touch with myself after a long period of not being in touch with myself. I became more confident or more caring. I always knew that it's important to feel good about oneself or to care about oneself in order to be able to care also for other people. I mean, even if you want to be helpful for others, it's better if you're okay with yourself than if you're just angry. So there were huge reliefs from taking hormones. In these instances, participants describe substantial impacts of testosterone therapy, not only on their sense of well-being and mental health, but on their relationships with and ability to care for both themselves and others. Trans and non-binary participants reported that some of their healthcare providers also made statements that were patently out of alignment with current medical research on the impacts of testosterone therapy on fertility and the reproductive system. These advisements stemmed in some instances from lack of familiarity with the latest science on trans reproductive health, and in others from earlier ambiguity and uncertainty in the science on trans reproductive health itself. For example, according to many participants, their healthcare providers told them resolutely that if they started testosterone, they wouldn't be able to have a child later. Indeed, one participant reported signing an informed consent statement from their provider that stated taking testosterone would render them infertile. Another participant told us that his provider informed him that he would need a hysterectomy within 2 years of beginning testosterone or would likely face cancer. One healthcare provider we interviewed, when asked what they tell their patients about fertility preservation, said, "I talk about the function, largely irreversibly nature, of hormone therapy on gonadal function." They went on to acknowledge that pausing testosterone therapy during pregnancy is, quote, incredibly difficult, and that a number of their patients have stopped trying to become pregnant because, quote, it's just too hard to be without hormones. This provider noted that they were not the one to prescribe hormones to their patients and remarked, "I only wonder about the quality of the counseling beforehand, because often when people want to start hormones, their desire to start hormones is so great that they're a little, blinkered perhaps. The need to start hormones is so great that it overrides any other consideration." Here, the healthcare provider offers both inaccurate medical advice and a cisnormative and patronizing view that trans and non-binary patients' desire to begin hormone therapy results in a blinder that obscures their ability to suitably envision potentially competing future desires, such as pregnancy. In stark contrast to this view, one participant told us, "When I was 24, I knew I wanted to have a child. But I knew I was not able to get pregnant as a woman. It was not possible. I knew I could not bear people, the view other people would have of me." In this participant's life history, their desires to take testosterone, live in the world as a man, be socially recognized by others as a man, and become pregnant were not inconsonant. Rather, the possibility of being pregnant as a woman is what was seen as incommensurate with his well-being and his sense of self in the world. This trans life world, understanding of life possibilities, and vision for the future provides an important alternative to the cisnormative assumptions some healthcare providers we interviewed expressed. This experience also aligns with patients' desires to use hormone therapies in ways that may not fully conform to one-size-fits-all universalized assumptions about the correct dose of testosterone for all trans and non-binary patients. As one participant said, "I had friends that took very low doses. They didn't need a doctor to tell them you have to take this amount, otherwise that's not good for health. So I knew a lot of people who experimented with their doses. I knew it would be fine for me too." Further, healthcare provider views that trans and non-binary people who wish to pursue tailored testosterone dosing or who worry about pausing testosterone during pregnancy are selfish or have on blinders, fail to consider the myriad cisnormative structural barriers to culturally competent care that their patients face. For example, as one participant told us, "When you want to change your first name here, or if you want to change your legal sex on a passport, you have to have 2 reports from psychologists stating that you are, quote, irreversibly trans, always played with cars and never played with dolls, stuff like this. I didn't dare to say anything about wanting to have a child. I knew I wanted to get pregnant and I would manage to get pregnant, but I never sought any support from healthcare providers because I did not think that they would support me. I even feared they would stop me. As another participant told us, a lot of my relationship with medical care was really around telling people what they needed to hear from me to get the medical care that I needed, rather than go to medical professionals for opinions and advice. As such, rather than wearing blinders, the trans and non-binary participants we interviewed described strategic and pragmatic approaches for negotiating gatekeeping practices of state and healthcare systems and providers in order to obtain the services they needed to ensure their present and future well-being and life possibilities in the context of cisnormative and transphobic socio-medical practices. Given that healthcare professionals are often ill-equipped to offer empirically supported advice around pausing testosterone while seeking to conceive, as well as during and after pregnancy, many trans and non-binary people have turned to others for experience-based advice. For example, one participant discussed his experience seeking information about whether being on testosterone while chest feeding would be safe after not finding useful information from several healthcare providers. He said, most healthcare providers didn't even want to know whether I can chest feed and take testosterone. They said, why don't you just stop chest feeding? And I said, why should I? If this is my child's need and my need is to take testosterone, why isn't it possible to do both? And then I met one lactation specialist and she was interested and wanted to know more and started to do some research. And then she told me, yeah, you can do that. Go ahead. His lactation consultant's stated rationale for this advice was that children do not yet have active hormone receptors. So exposure to human milk with higher concentrations of testosterone should not result in negative impacts. While he was not ultimately sure about the accuracy of this advice, he pursued a harm reduction approach and reduced his testosterone dosage during the time that he was chest feeding his child. One participant discussed his complex feelings about the possibility of testosterone therapy during pregnancy. He said, there's also a bunch of research around androgen exposure in utero and intersex conditions, and even some around stress hormones and cortisol and androgen in intersex babies. I did have complex feelings around working hard to not have an intersex child. As someone who is a gender other, to work hard to not create a different body that is a gender other, it feels weird, feels a little hypocritical. But it kind of came down to wanting the child I created to have the most options in their own body, in their own life. And most intersex folks don't have fertility options open to them. But I had had a lot of big feelings at the time around, okay, what does it mean to make sure that a child isn't exposed to androgens? And is this the right thing? Another participant described not finding out that they were pregnant until they were 10 weeks into the pregnancy, and after taking 3 testosterone injections. This participant elected to pause testosterone therapy upon learning of the pregnancy, but did so reluctantly and reported feeling a bit shaken by the experience. He said, when the testosterone left my system, I felt as weird as I did before testosterone, but kind of worse because I've got other hormones going on as well. So yeah, it was just not good. The harm reduction approaches some of our participants described sought to attend both to their own health and well-being and the potential health and well-being of their future offspring. Healthcare providers are not always willing and able, however, to grapple with harm reduction approaches, as they differ from cultural norms and expectations that gestational parents must always and automatically self-sacrifice, or choose optimal approaches that exclusively prioritize the potential well-being of offspring. When one participant requested that their doctor perform a blood test to ensure that their child wasn't being negatively impacted by testosterone exposure through their milk, their doctor refused. Quote, the doctor did not agree on doing a blood test because they said they could not test it because they don't have a norm. They need to have a norm to compare it to. Otherwise, they can't say whether it's more or less than it should be. In such instances, healthcare providers may have incomplete or conflicting empirical information about whether a practice is safe or not, and may also not have reliable tools or markers for gauging the potential or actual health impacts of various actions. In these contexts of uncertainty and ambiguity, advice to simply refrain from particular behaviors, like taking testosterone while pregnant or chest feeding, may become the most likely fallback. However, such medical advice is also not without potentially negative health and well-being consequences for both trans and non-binary people and their offspring, including possibilities that a trans or non-binary parent may stop or choose not to chest feed, choose not to pursue pregnancy at all, or face negative physical or mental health consequences from pausing testosterone therapy while pregnant or chest feeding, some of which may make postpartum infant care either difficult or impossible. One of the more nuanced responses from a healthcare provider on questions about continuation of testosterone during pregnancy and the postpartum period came from one of the providers that I'm going to quote a bit at length to you right now. They said, any presentation I go to, they're just like, testosterone's a teratogen. And when I'm presenting on it, I'd say, we consider it teratogenic based on extremely limited data and conflicting data. I think to some degree, we can look at data on PCOS and pregnancy as a population or people that has increased testosterone levels, not as increased as they would be if you were taking a full dose of testosterone. And we see that there's some impact there, but we don't change our pregnancy care. We don't try to reduce those testosterone levels. We just take care of the pregnant person. I think it's probably not a great idea for people to say, stay on T when they're pregnant. But I feel like we do this thing where we present the data, we present it with a lot more clarity or certainty than we actually have. What I'd really like to know more about in terms of testosterone is chest feeding, because a lot of people in my experience, a lot of people I've talked to, patients or social media or whatever, say, I'm totally good not being on T for the pregnancy. That makes sense to me. But once I'm not pregnant anymore, I really want to be back on T, but I also really want to be able to feed my baby human milk. And this is the way that I can do it. We don't have studies on pregnant people and breastfeeding people for a reason, because a lot of it would not be ethical. But I would like to have a better sense of safety with chest feeding and testosterone for sure. A second healthcare provider we interviewed placed their concerns about a client taking testosterone during pregnancy in relation to the fuller spectrum of other concerns they may have. She said, honestly, on my list of things that I'm worried about in pregnancy, it's so far down the list that I don't even go there. My patients have a higher than average rate of substance use, of sexually transmitted infections, of chronic stress related to marginalized status. Exogenous hormones are not my first concern. The fact that there's very little data is concerning, but we give people medications all the time that have very little data in pregnancy. So we can talk through what's known and what's not known, and people can make their decisions. But it's not something I'm prioritizing my anxiety about. I mean, I would talk to him frankly about the fact that we don't have as much data as I would like. I just try to stick to the things that we can modify, that we do have data on. And I'm very open with people that we don't know, to say that we don't know what the risks are. And this is what we will go forward with. I've not come across anyone who was like, no, absolutely, I want to continue with testosterone. But just given the data that we have, I just have a really hard time being hardcore about it. And I would never risk somebody out of care for that. These providers' willingness to confront and seriously grapple with the existing uncertainty and ambiguity of the empirical data on testosterone therapy during pregnancy and the postpartum period, all while providing information, support, and care for trans and non-binary pregnant patients, served as illuminating exceptions to the general trend to view consideration of any testosterone therapy during pregnancy and the postpartum period as verboten. So just how do we make sense of all of this? Sex hormones are often misunderstood as the dimorphic chemical building blocks of gender. The lessons that we can learn from medical authorities' work to manage and regulate access and use of such hormones, however, suggest that the case is much more complicated. Indeed, there's much to learn about gender, medicine, and biological and social reproduction if we're willing to ask different questions. We find that the medical science around the potential impacts of natal parent testosterone therapy on fetal development in utero or infant secondary exposure during the postpartum period remains nascent at best. In this context of medical ambiguity and uncertainty, healthcare providers and trans and non-binary patients tend to prioritize potential fetal and infant health and well-being and imaginaries concerning future offspring's normative development over trans and non-binary patient health, and particularly mental health and well-being in the present. Previous research repeatedly demonstrates how ambiguity and uncertainty in the context of medical treatment of pregnant trans and non-binary people is associated with healthcare providers engaging in authority re-establishing practices that may either intentionally or inadvertently involve stigma, discrimination, and poor care. As Steph Schuster notes, underpinning trans medicine is the inescapable fact that providers are working within gender-specific medicine. Gender normative expression becomes a lens through which providers make distinctions of good and bad patients. As such, part of being a good pregnant patient as a trans or non-binary person involves pausing testosterone therapy, even if it may involve significant negative impacts on one's own mental health and well-being. Part of being a good doctor, too, involves rule following in the context of medical practice in order to meet expectations of professionalism. Further, few medical professionals receive comprehensive training on trans and non-binary pregnancy care and are left to rely instead on standards and norms created with other groups or within other bureaucratized systems. The logics guiding current medical advice around testosterone therapy pause in pregnancy involves potentially troubling assessments of the sorts of risks testosterone exposure in the prenatal and postpartum environments may pose for later child and adult development, namely potentially heightened likelihoods of autism, obesity, intersex conditions, lesbian identity, and transgender identity. In this way, the practice of protecting the offspring of trans and non-binary people in this context becomes paradoxically a method for ensuring against reproduction of some of the very same characteristics held by some trans and non-binary parents themselves. We also find that despite relatively standard medical advice for trans and non-binary people to pause testosterone therapy prior to conception, during the gestational period, and across the duration of chest feeding, there remains relatively scant empirical evidence guiding that advisement, particularly in the context of testosterone microdosing. As Steph Schuster notes, much of trans medicine has been built on the assumption of binary genders. Trans people's understandings of their selves and bodies have become more fluid, and cross-gender transitioning is not always the ultimate goal. Indeed, future medical research might approach continuation of testosterone during pregnancy among trans and non-binary people, not as a binary yes-no question or a topic to approach for the purpose of developing one-size-fits-all medical standardization and dosing, but one that investigates the potential impacts on trans and non-binary patients and their offspring of continuing various dosages of testosterone across pregnancy. We argue that medicine's refusal to consider the possibility of trans men and non-binary people continuing testosterone therapy during pregnancy to be a striking example of what Emily Payne has described as embodied disruption, or how patients' embodied nonconformity to binary medical constructs disrupts ordinary medical interactions, and how provider reactions prevent gender nonconforming patients from meeting their healthcare needs. The fact that a common parallel to some trans and non-binary people's potential androgen excess in pregnancy has long existed among cis women provides additional insights and pathways for further consideration. Indeed, PCOS affects as many as 1 in 10 people of reproductive age who have ovaries, often resulting in higher endogenous levels of testosterone and consequently some of the same physical characteristics many trans men and non-binary people seek to develop. While higher levels of testosterone may make it more difficult to become and remain pregnant, those diagnosed with PCOS are not routinely placed on testosterone blockers during pregnancy or discouraged from feeding their infants milk that they produce. Many of those with PCOS, however, are routinely counseled to lose, quote, excess weight and limit the amount of weight gained across pregnancy. Despite conflicting empirical evidence, they're also frequently informed that failing to do so may make it more likely that their offspring will have a higher risk of developing the aforementioned characteristics in the future, intending to compel those with PCOS to engage in behavior modification practices with the intention of not bearing offspring with some of the very same socially undesirable and deemed unhealthy characteristics they often have themselves. Drawing upon sociological theorizing around social control, social normativity, and social fitness, in this work, we've considered just what is at stake as healthcare providers and trans and non-binary people interface in the context of pregnancy to make decisions around testosterone therapy. This case provides an opportunity to discern how these medically managed and often highly consequential decision-making processes emerge in an environment of incomplete and conflicting empirical medical evidence. Of particular focus in this work is which needs and whose well-being are protected and challenged as these decisions are made, and to what personal and social consequences. Through imagining alternative possibilities for current medical practices around recommendations to pause testosterone therapy during pregnancy, there may be opportunities to develop healthcare practices for trans and non-binary people that better meet their mental and physical healthcare needs using more tailored approaches. This work aims to make room to consider possibilities of testosterone therapy during pregnancy for trans and non-binary people, with a call to attend more fully to the mental and physical health of trans and non-binary people alongside their potential offspring. Doing so addresses not only the artificial binarization of sex and gender in medicine and society, but that between mental and physical health as well, as it urges more holistic focus on the health and well-being of trans and non-binary people before, during, and after pregnancy. I want to thank you for listening and for attending today's session, and I am really excited to hear your questions and your comments. Thank you.
Thank you so much, Carla. Just anybody who wants to put their questions either in the chat or in the Q&A, please go right ahead. I'll just a reminder that you will receive a link to respond with the survey tomorrow, but if you want to respond to that Qualtrics survey right now, Edwin has put that link in the chat. So are there any questions that people would like to pose to Professor Pfeffer? And sometimes people are a little shy. I have one. So kind of related, I think, somewhat to the methods, right? So I'm assuming that most of the pregnant people in your sample had transitioned as adults. And maybe that's not true, but I'm wondering how, because we have this growing number of younger people transitioning at younger ages, sometimes never going through the cis puberty and transitioning before the onset of puberty. And I don't know how, I'm really still learning everything that hormones do and don't do. So I'm curious how maybe physically that changes the experience of like what their needs are in terms of physical needs, in terms of transitioning and pregnancy, if that changes the kind of weighing the pros and cons, given that there's such little research on it anyway, and how that might, this might be just kind of like, extrapolating, but how that might affect their own identity in this, having never really, not that they never experienced gender dysphoria, but never had to sit in that embodied experience of being in the wrong body for years and years and years before they had, right? So if going off of testosterone while you're pregnant, if that creates a really different experience because they've never had that experience of not having that testosterone when they were, post-pubescent?
Yeah, those are such great questions. And I mean, we really don't know yet, right? Because essentially what we're talking about are different cohorts of trans and non-binary people, right? Where if we take a look at earlier cohorts, there just weren't opportunities to pause puberty, right? Or, take puberty blockers and then take hormone therapy that's consonant with gender identity. If those options weren't really present, were the folks that I'm interviewing, the folks that we interviewed for this project, largely went through that earlier cohort experience where they did go through a puberty that for many of them may not have felt like it was the right puberty for them to go through. But it did also allow for maturation of their ova, right? In a particular context. What will happen as we begin to push for greater access for trans and non-binary folks to be able to undergo puberty suppression and then treatment with hormone therapy that is consonant with their gender identity, what will happen for reproductive futures? We don't have all of that data yet because we don't have a large enough cohort of folks who have been really kind of undergoing these experiences for quite some time now. So our data tend to be much more short-term, much more limited. But there are, researchers, there are doctors who are trying to figure out how do we work with wanting to suppress hormones, but also protecting the reproductive futures of those who wish to have children at a later date using their own gametes. So those are still sort of questions that science is trying to figure out, that doctors are trying to figure out, that parents and kids are trying to find out, together. And quite frankly, they're doing it in a horrifying political onslaught, where we're seeing nationally and locally, an enormous drive to characterize puberty suppression and hormone therapy, which is best practices right now in trans healthcare, as criminal, right? So even here in Michigan, there's a House bill that would criminalize parents and providers who support their children in accessing gender affirming medical care with penalties up to lifelong imprisonment. So, these are questions that are unfolding in some really unstable and terrifying, I would say, political context right now.
Yes, and I'm glad you brought up that House bill in Michigan because, yeah, something we all elections coming up, folks. So keep that in mind when you go to the polls. So Patrick Arnold has a question. Awesome research. Could you say anything more about whether differences emerge between trans men and those that specifically identified as non-binary, especially those that would eschew identifying as men, in navigating testosterone usage during pregnancy? For instance, were specifically non-binary participants more likely to be willing to pause or reduce testosterone therapy? Did they report poor experiences with HCPs?
Yeah, so the biggest challenge that we saw for non-binary participants is their providers wanting to kind of default to standardized dosing, protocols. I mean, there aren't really protocols, right? But the Endocrine Society says you should be in a lot of reproductive endocrinologists, some family care providers. A lot of folks will use Endocrine Society guidelines. And so those guidelines say you basically medicate with testosterone until serum testosterone levels reach those that would be expected in the range for cisgender men. And a lot of non-binary folks say that is too much, or I'm not really interested in taking that much testosterone. I want some effects, but I'm not looking for all the effects that I'm going to get in a dosage that would be associated with attaining serum levels at the normal level among cisgender men. And so they would often sometimes receive pushback from their providers. They talked about shopping for providers, talking with community members about, which providers have you found that are willing to work with you to help you achieve your aims rather than just trying to impose a medical standard. So they did talk about kind of having to often work within the community and find recommendations and advice and providers through those channels to make it easier for them to obtain the medical care that they sought and the sorts of medical treatment that they wanted. And these were fully informed patients, right? So they had a lot of information already from the community. A lot of them had been reading medical journals and articles. You have to find out a lot of information on your own when a lot of your intentions are thwarted by medical healthcare providers. And a lot of the non-binary folks we interviewed were doing just that, being quite innovative in their conversations with practitioners about getting the care they needed.
So Megan Dean has a question. Thank you so much for your talk. I was wondering if you noticed differences amongst the experiences of trans and non-binary folks and the providers by nationality. As you just mentioned, the political context seemed quite different in some of the places you all did research.
Yeah, they really are. One of the most striking differences, and I was just talking to somebody else about this, that I noticed was that it seemed that in the UK-based subsample, so these are folks who have the national health system, they have nationalized healthcare, a lot of the advice that they were receiving from healthcare providers and the information they were receiving from healthcare providers up until relatively recently suggested, their providers were suggesting to them, or often stating outright to them, that testosterone therapy was sterilizing, that they would not be able to become pregnant while on testosterone therapy, which is patently untrue, and kind of placed a lot of the patients under the care of these physicians at risk for unintended pregnancy if they weren't, protecting themselves using birth control methods, barrier methods, whatever methods, when having sex with folks who produce sperm. So this was a problem that we saw in the UK, kind of just providers following much older medical guidance and medical science in trans health and trans reproductive health specifically. We've known for quite some time now, certainly over a decade, that you can certainly get pregnant while on testosterone. But a lot of the practitioners, especially in some of the smaller regions providing, healthcare, weren't conveying this information to their patients. So that was one big difference that we saw. I spoke a little bit about some of the difference between non-binary patients or non-binary participants and the trans men participants we spoke to in being, wanting to have different forms or different levels of testosterone dosing and challenges around provider care there. And also our non-binary patients or participants talked a lot about their providers really struggling around not falling into binary ways of referring to them and their bodies and pronouns in the healthcare interaction. So a lot of providers, even those who were, claimed expertise with trans and non-binary health, seemed much more comfortable talking to their trans men patients and using the correct pronouns than they were when speaking with and working with non-binary clients. Some expressed physical expressions of discomfort when seeing kind of cross-gender sex phenotypes. So, having a beard, but also wearing skirts or dresses, just self-presenting in ways that go against the binary. Some providers seemed uncomfortable with that, or would have a lot more of a challenge using non-binary pronouns. So they did talk about some of those challenges that they experienced with their healthcare and healthcare providers.
And was there a difference across different countries in terms of who had trouble with the non-binary patients more?
Not so much. We didn't see big regional or geographic distinctions. That seemed to be fairly uniform between the United States and Italy. And I will say that Italian providers, it was in the interviews with Italian providers where many of them just really did not have much familiarity with working with actual trans and non-binary participants. They kind of pursued a lot of what they were doing more theoretically than practically. They just didn't have a high caseload of trans and non-binary patients. So their practice levels were much reduced compared to practitioners in other spaces, the UK, Germany, even, United States, certainly. So we did see some differences there.
It's interesting.
Yeah.
So Kalia Roberts writes, "This was a fantastic presentation. Thank you so much. I was wondering whether your analysis had looked in any way, at the race, ethnicity, indigenous status of the patient impacts, how it impacted the advice they received, particularly in light of the fact that the advice is clearly impacted by cis heteronormative standards, and the application of such standards has often served white supremacy.
Yeah, so we have that data, and we use axial coding to be able to kind of speak to differences in race, indigeneity. We're able to take a look at those categories using axial coding across different variables that we've coded for. I would say that some of the biggest distinctions that we find are that among our trans patients and non-binary patients and participants of color, a lot of what was going on is kind of physicians' lack of awareness about how race might matter in their counseling and in their guidance and advisements, including just, and this isn't only, of course, for patients and participants of color, but also for participants who were poorer, who reported lower socioeconomic status. A lot of them weren't really considering how impacts of economics and the ability to afford some of the reproductive measures and some of the assistance around reproduction isn't accessible to a lot of folks. And they would often kind of present possibilities, but they wouldn't be real possibilities in the life worlds of patients who couldn't afford or access those possibilities. Some patients also told us about their providers not being aware of, skin differences in healing on certain surgical procedures that folks may have, and the issues around keloid formation, so development of scar tissue in darker skin or more highly pigmented skin, and how to deal with keloid formation and prevent keloid formation. So it really went all the way from kind of the hypothetical in healthcare provision all the way to the very practical provision of healthcare provision, and not necessarily kind of thinking about how these things might matter. In terms of indigeneity, largely we found that citizenship issues are a huge area of concern, because whether or not you are considered a citizen, especially in countries that are providing nationalized healthcare, whether or not you have access to those services, it's often precluded if you don't have citizenship rights in that country. And some folks that we spoke with talked about being in partnerships where there was mixed status among and between partners, where one partner was white or a citizen, and another partner was not a citizen or was not white, and what that meant in the healthcare provider and kind of couple unit dynamic, the conversations that would happen. Some folks talked about having doctors speak to their white partner instead of talking to them, even though they were the identified patient. So just kind of those microaggressions, really aggressions that are happening within healthcare provider contexts that happen at the intersection of gender, racialization, gender and racialization practices were pretty remarkable to the participants that we interviewed when they happened, because you're there and you're already worried and you're already on edge. And then this is another layer that complicates that. Mm-hmm. The rapport that you develop with a provider and feeling like your needs and interests are really being understood and attended to.
Thank you. That's a great answer. Are there any other questions, or if people would like to ask their question live, you can raise your hand. I'm just going to double check the chat. I don't see anything. Well, with that, I will thank you very much, Professor Pfeffer. It was really a fascinating talk. We will have this up in about a week, so feel free to link to it. We'll share it. If those of you who are in attendance, if you know somebody who couldn't make it, you can send them this link as well. And thank you all for coming. And thank you so much, Carla. This was really, really eye-opening. I appreciate it.
Thank you so much. And thank you for everyone for showing up on a Friday, and enjoy your weekends.
Take care, all.
Bye.